and welcome to TEDMED's live events focusing on the great challenge of preparing for the dementia tsunami. I'm Judy Bachrach. I'll be moderating today's discussion, which will run about an hour. The session is part of the Great Challenges program sponsored by the Robert Wood Johnson Foundation. The goal of the Great Challenges program is to look at 20 of the most complex problems in health and medicine, issues that can't be solved with a magic bullet or policy. Our mission is not to solve these issues, but to share ideas from many disciplines to reach a better understanding of them than we had before. We'll be taking questions from viewers on Google Hangout and on Facebook and on Twitter. That's Twitter @TEDMED. Just tag your questions with hashtag Great Challenges and we'll try to get to them. As mentioned, my name is Judy Bachrach. I'm a contributing editor at Vanity Fair. I have a mother who has Alzheimer's, so I know the disease only too well, and TEDMED has asked me to moderate today's events. Today, we're delighted to welcome a great team of experts who we call our challenge team to lead the discussion on this topic. Our first guest is Dr. Sharon Brangman. Dr. Brangman is a board certified in internal medicine and geriatric medicine. We also have Guy Eakin, the Vice President of Scientific Affairs at the Bright Focus Foundation. Guy leads the foundation's efforts to identify promising and innovative research to combat Alzheimer's, macular degeneration, and glaucoma. We also have Dr. Sam Fazio. He's Director of Special Projects at the Alzheimer's Association. Dr. Fazio has worked for the Alzheimer's Association since 1994, and he currently works in constituent services where he oversees quality care standards and social and behavioral research initiatives. And finally, but not least, we have George Vredenberg. George is the chairman and co-founder of the Us Against Alzheimer's Network and Us Against Alzheimer's, a nonprofit education and advocacy network and campaign. They are committed to educating and mobilizing America to stop Alzheimer's by 2020. Welcome, everyone. And just so everybody knows, 2020 is an important year because by that time, we understand there'll be more than 43 million Americans over the age of 65 and 15 million over the age of 85. That's huge. That is twice the figures that we had in 1985 of older Americans. At this time, 1 in 8 older Americans has Alzheimer's, and that's according to the Alzheimer's Association. So we're going to have, as this series is called, a tsunami of dementia. I think you all know that people are getting older and older, not only in the United States, but all over the world. So Dr. Brangman, let's start with you. What are we going to do to make that dementia tsunami a non-issue, or at least less of an issue than it appears to be right now?
Well, one of the most important factors, I think, is training all healthcare professionals. That includes doctors, nurses, therapists, pharmacists. Everyone needs to be aware of the issues of our aging population, and more specifically, they need to have the skills to manage people with cognitive impairment. We know that the fastest growing segment of our population are those people who are 85 and older, and that's where the biggest risk for Alzheimer's disease is.
Well, that may be, but of course, I'm sure a lot of people out there listening now are worrying about their loved ones as well as themselves and their friends, and they're thinking, oh gee, what a choice. I either get to die before 85 or I get dementia of some sort, perhaps Alzheimer's. So I'm going to ask you, Dr. Fazio, are there initiatives right now, medical initiatives, that might give these people hope and encouragement?
Well, yeah, I think there's a lot out there right now that's looking to give people hope. There's all different types of research going on, things around biomarkers and early detection and different treatments. I think a lot more research is needed, and I think that's what's so important. Alzheimer's has been underfunded in the past, and we really need to really look at the epidemic of this disease and put more federal funding towards it so we can really hit the research hard and really help these families who are going to be in need.
I'm going to go to Guy Eakin right now and ask him, well, what specifically are the advances that are being made that could give people hope?
Sure. Well, before I get to that, let me just say the scale of the problem that Dr. Brangman mentioned is huge. You know, right now, we have less than 1% of our nurses, our physician's assistants, and our pharmacists are certified in geriatrics. But 26% of their patient visits are from geriatric populations. I mean, that's a huge discrepancy. So training programs are immensely necessary. When you're asking about the research advances we see, Dr. Fazio very appropriately alluded to the biomarker projects that are going on. The Alzheimer's Association has been great with some neuroimaging work. There's also a lot of basic science that's occurred just in the last year. We've seen for the first time how Alzheimer's disease might be spreading within the brain from cell to cell. There have been revealed ways of how Alzheimer's disease proteins may be cleared from the brain, but all of this is impeded by a very true lack of funding that we have for this disease. Right now, Alzheimer's disease, as many of the people on this panel know, it's, and I think as you mentioned, it's one of the top 10 killers of citizens of the United States. It's the only one without a disease-modifying treatment, and it gets about a quarter to a half of the funding of the other diseases on that top 10 list. But certainly the biomarkers, the early detection are some of the research advances that are going on. We're particularly interested in the opportunities to repurpose drugs, the existing FDA-approved drugs, to see if they might be used for an Alzheimer's indication.
I guess I'm going to follow that up with a brief question, which is, I think the biomarkers, if I'm not mistaken, simply tell you that whether the disease is possibly likely to occur. I don't think it gives anybody hope of a cure, and I think the protein inhibitors have not been proven successful, if I'm not mistaken. Am I correct there?
You're correct, but I think we have to think a little bit further outside of ourselves when we're talking about these biomarkers. Whether or not they're giving us a hope for a cure, at an individual level, they give us the opportunity for some things. Maybe they give us the opportunity for advanced planning, how we want our affairs to be handled. You're correct. We don't have any disease-modifying treatments right now, but we aren't going to have any disease-modifying treatments unless we have these biomarkers and an ability to detect this disease earlier and earlier in the natural development of the disease. What we saw from these clinical trials that you referenced this last year is that if there's any signal for hope, it's catching the disease early. And if biomarkers and various diagnostics that are available are going to be the only way of catching the disease early.
Thank you. George Radenberg, since we're talking about money, and I'm sure you're concerned about money when we're talking about dementia as well as Alzheimer's, what are we talking about when we're talking about huge cuts in Alzheimer's and dementia funding? What are we talking about? What are the numbers?
Well, today we spend about $6 billion a year on cancer research, about $3 billion on HIV/AIDS research, and less than $500 million a year on Alzheimer's research. If the sequester goes into effect next week or 10 days, then the NIH funding for new grants is going to drop precipitously, and that includes for Alzheimer's as well as other diseases. As a consequence, new granting will be significantly down. Multi-year grants will play out, but the new grants will play down. So that is a big and significant problem. But let me talk about money in another sense. The cost of caring for those with Alzheimer's today is over $200 billion a year and estimated to rise to over $1 trillion a year in the coming decades. So the cost problem here is an enormous one for the country. And if you thought that we were investing $500 million a year against a problem that was costing the American people and the American taxpayers $200 billion a year, you'd say something was wrong with that picture. And something is wrong with that picture. This is not just a human health problem. It's a problem of our fiscal sustainability and the economic costs on society of having so many families having to pull out of the workforce to take care of a loved one who has Alzheimer's or dementia.
Did I really hear you correctly? Just 500 million on Alzheimer's and dementia overall?
At the NIH, yes.
At the NIH. Considering that more and more people are getting older and older in the United States, how come there hasn't been a massive revolution, if you will, of people who are getting older and who are concerned about the future, as well as concerned about the future of people who might care for them, their children, their grandchildren?
I think there's growing awareness now as baby boomers are turning 65 at the rate of 10,000 today, and there will be for the next 17 or 18 years. So I think the problem is growing as the baby boomers are seeing this happen with their parents and wondering, I do not want to have my children do for me what I'm having to do for my parents today. So I think baby boomers have shifted attitudes historically in a wide variety of ways, and I think that they will have a marked impact as baby boomers continue to turn 65. But part of the problem here is that the victim of Alzheimer's really can't speak for themselves. They really have lost the ability to communicate. There's a great deal of social isolation, and the caregiver is so exhausted and probably suffering a degree of depression themselves for what they're having to do, and the time suck that goes on in trying to take care of a loved one, that the caregiver does not have much of a voice either. And so it is up to us, the rest of us who are out there advocating for those with the disease or those who are taking care of them, to be the voice of those who really cannot speak for themselves.
Well, thank you.
I just wanted
to, I think you were going to tell us something.
Yes, I was just going to kind of add on to what George was saying, is that I think as a culture and a society, we're very youth-oriented. Everything is focused on staying young and doing superficial things to look younger, and we have not taken seriously the issues of aging. And because we have this fear and this denial about aging, we have overlooked some of the major issues that can affect your quality of life as you get older. The other thing that
Sorry, go ahead, Dr. Bregman.
Well, the other thing that I was just going to point out is that we do not have a cure right now. We don't have any drugs that modify the disease. However, there are things that we can do that will possibly push back that time before we get dementia. And we have increasing information that suggests that being physically active, doing weights, doing exercise in a really deliberate manner can help to reduce those risks. And again, as a society, that's something that we don't really want to do. We all look for that closest parking spot near the mall and don't do very much to kind of keep ourselves physically active. And we know that that has a big impact on brain health.
That's interesting. Does anybody else know any other things we might do to stave off the day we have Alzheimer's or dementia? Anything, any other possibilities besides exercise, weights, regular activity?
There's no question that all the risk factors for cardiovascular disease and diabetes seem to relate to increased incidence of Alzheimer's. And so there's some relationship going on in the body between what's happening in the metabolic system, whether diabetes, and what's happening in our cardiovascular system. It's like being healthy more generally obviously gives you greater resistance to virtually any disease. There's nothing that stops Alzheimer's. It doesn't stop the disease. It just gives your body a slightly greater capacity potentially to resist for a period of time. So I think there's nothing that will substitute for an innovative treatment for this disease. There was a concern in the 50s and 60s that the number of polio victims in this country was going to cause the creation of iron lung hospitals and an enormous iron lung manufacturing and leg brace industry. And the reason we don't have polio healthcare costs today is not because we've been very, very good at efficiently manufacturing iron lungs, but because we had innovated a treatment for that disease. So there's nothing that is going to be more effective in putting off this disease than the disease-modifying drug, which will defer the onset of symptoms or slow them down, and eventually a second and third generation drug that will actually stop the disease. And as Guy mentioned, one of the more promising things with all the diagnostic capability we've developed and the ability to tell whether or not that you're at risk for this disease 10, 20, and 30 years before the symptoms appear is that we now have major prevention trials that are going to be launched by the end of this year or early next year into interventions that occur in patients who have no symptoms and in the hope and expectation that we're going to be able to identify the treatment that will cause the disease to be deferred or delayed or slowed down in a way that will extend quality of life and hopefully prevent the onset of disability, the onset of dementing symptoms. Even though you may have the disease, if you don't have the symptoms, you still have your cognition and still have your functionality. To some extent, you could manage this disease if we can find a treatment that will defer or extend the length of time of the disease.
Dr. Eakin, if I can ask you a question, and it came from Twitter. What can we learn from other countries about how to handle the issue of dementia, Alzheimer's?
Well, you know, my expertise is certainly in the research area, not necessarily in the care. Different countries do have very unique circumstances. I point to China, for instance, where the decades of the one-child policies have skewed their demographics so that they face a very enormous concern for Alzheimer's disease. If you don't mind, I'd like to actually address something that follow up on something George was saying about these prevention trials. These prevention trials don't happen by magic. They require a lot to get them going, and one of those things is people. And we just do not have enough clinical volunteers for clinical trials right now. So prevention trials, you know, right now the trials that are being tested that we heard about in the news last fall, they involve 2,000 patients. The trials that are being talked about for some of the prevention trials are 30,000 patients. Enrolling these people is going to be very, very tough. And so we need to find new ways of getting people engaged in research, contributing their own personal data into research. And our organization, along with George's, is very proud to be part of the 21st Century Brain Trust.
Can I stop you there a second?
Sure.
Why haven't people come forth, or their relatives or their friends bring them forth? Why is there such a dearth of volunteers?
Well,
please share it.
Oh, I was just going to say the caregiving process is so consuming, and I see families all the time that are just completely consumed with taking care of their loved one. If they do get a moment free, the last thing they want to do is go and spend more time dealing with Alzheimer's disease. And then after they're done, they're exhausted. There are few people that might have enough energy to start in another direction to help make some change. But most people are emotionally and financially and sometimes even physically spent. You may have seen some of the research that shows that the caregivers of patients with Alzheimer's disease have the highest rate of depression and often neglect their own health. So it's almost too much to ask them to do yet something else, something more when they're taking care of a loved one.
Well, Dr. Bragman, while I have you on, I'm going to ask you if you can respond to this very interesting question from Twitter. Once again, it's what can we learn from how other countries respond to the issue? What is France doing? What is Japan doing? Can you tell us?
I really think the United States is the leader here. I think that we see a demographic shift in the whole world where there are fewer younger people and increasing older people. And I don't really think there's any one country or system that's doing it any better, because I think we're all dealing with the same issues. We have limited resources and large numbers.
Sam, perhaps you have a thought on this too?
Yeah, I'd like to add a couple of things. Just a bit back to the clinical studies. I think another big issue is that that some people aren't even aware that they exist, and they're out out there. And, you know, the Alzheimer's Association has something called Trial Match that tries to connect people with trials in their area. And so I think a lot of it is about education about trials and about the importance of them and that they're available in their communities. So I'll just touch on that. But then also on your question about care in other parts of the countries, I think that there are exciting things going on all over the world. And, you know, there are many countries that have national Alzheimer's plans, and now we're in the process of really formalizing our Alzheimer's plan that really is going to put more focus on spending and on research money and on care. And so I think that's important that we're sort of joining that bandwagon with the other countries. I think also some other countries really pay more significant attention to the person with the disease and person-centered care. You know, that whole concept of person-centered care began in the UK, which really focuses on the individual's personal needs and relationships associated with that care. And so we've learned a lot from other countries about what good care looks like and how to help put out guidelines for others about what that is.
You mentioned Britain. Any other country?
You know, there's a bunch of other countries. I mean, Australia, you know, other countries in Europe. So a lot of folks are really looking at care a little bit differently than we look in the U.S., where it's really more person-centered and more holistic.
If I could, just a comment. This country does not have a coherent long-term care plan. We have pieces of Medicaid that deal with it, pieces of Medicare that deal with it, you know, pieces of the Older Americans Act that deal with it, but there's nothing sort of comprehensive like other countries have with respect to long care plans. I recently been appointed to the Commission on Long-Term Care simply to figure out whether or not this country can develop a long-term care plan that in fact is understandable to people, where people can have a variety of choices, which is centered in home care, so that in fact we keep people at home as long as possible, that we in fact support the heck out of family caregivers in terms of training, in terms of assistive technologies and assistive services, so that they are regularly relieved, as well as well-trained and understand the behaviors that they're having to deal with and the conditions that they're having to cope with. So I think that whole issue of long-term care is something that we're going to have to tend to as a country, as other countries are beginning to do, because as Sharon mentioned, this is happening globally. It's, you know, we think of the United States, we're United States-centric, but there are 5 million or so victims of Alzheimer's and dementia in this country. There are 35 million, or maybe 38 million globally. There are over 100 million caregivers globally. The impact on the global economy is now 1% of global GDP, and the estimates are that we're going to have over 100 million dementia victims in the coming decades and several hundred million caregivers. We do not have a globe that is used to coping with older and aging populations. We have a globe that's finally coped with how to handle most of the problems of the young, although there's still clearly major elements of having to get at that globally. But we have not even focused yet, as at the World Health Organization or others, on the the care burdens and the disease burdens associated with aging.
Well, that brings me to another question from another one of our viewers online, Dr. Leslie Kernisa, who asks, how many billions of dollars do we spend on dementia caregivers, education and support, or maybe in this case, how many dollars, since it doesn't seem we're spending billions? Do you know, George?
Well, as I said, the overall costs of taking care, either a family cost or taxpayer costs, is roughly $200 billion or somewhat greater than that today. In terms of the actual amount of money spent on what was earlier mentioned as the cost of educating and making dementia-friendly and dementia-capable our healthcare system, or how to actually educate family caregivers into what they can expect and how to get access to services and how to get access to assistive technologies, we spend a trivial amount. We do not yet have a dementia-capable, dementia-friendly society or healthcare workforce, let alone the families that have to cope with this, who are experiencing sort of novel developments every day And yet there are hundreds of people and thousands of people who are experiencing the same thing, but we have not yet been able to, we do not yet have a benefit that educates family caregivers into what to expect, how to cope, where they can get additional resources, and how they can get assistive technologies to potentially monitor the person in their home with either dementia or some other disabling characteristic.
And then we also,
sorry, Dr. Bragman, go ahead.
I was just going to add that the healthcare workforce issue cannot be underemphasized. We now have physicians and doctors that can graduate from professional training having very little, if any, specific skills in taking care of older adults or Alzheimer's disease. And a lot of the ways that they are managed are old, out of date, and do not benefit the patient.
For example, Dr.
For example, when an older person gets admitted to the hospital and gets agitated, they're often sedated and given medications that don't help the aging brain do well. Or, for instance, say they have problems sleeping in the hospital, they may be given medicines that actually make the aging brain with dementia more confused, more likely to fall. We have an archaic nursing home system that's really based on a hospital model with care that is often delivered by others who haven't had specific training in Alzheimer's disease, which is really odd when most people in a nursing home do have Alzheimer's disease. So we need to completely retrain and look at the healthcare workforce. We currently have about 7,000 certified health professionals, physicians, nurses in this country with geriatric training, and we need about 16,000 right now, and increasing that, doubling that in the next coming decades, and we don't have that pipeline for that training.
The tragedy here is that, in fact, if we actually improve the workforce and improve the quality of care given either at home or in some community setting, that we will reduce the cost of care. Because we're over-medicating with psychotropic drugs, we're over-treating, we have hospital readmissions and thus Medicare transitions through skilled nursing facilities and rehab facilities that are excessive because we do not have an adequately trained workforce or family caregiver system to prevent those kinds of overutilization of the system or of drugs today. So there is, it seems to me, a line that says we can improve the quality of our dementia workforce and improve the quality of care in all care settings, and at the same time, over time, mitigate the rise in costs due to overutilization of either drugs or the healthcare system.
Dr. Bragman, I have a question for you again, and that is there are two fairly popular drugs on the market right now for those who have Alzheimer's or severe dementia, and one is Aricept and one is, I believe it's called Namenda. And I was wondering about your opinion of these drugs. Do they slow the progression of Alzheimer's or don't they?
Well, they have very individual responses. We don't know who they're going to help ahead of time, so we do offer those to most people. Aricept is in a class called cholinesterase inhibitors, and it includes other medicines such as rivastigmine and galantamine, and that should be something that's started in mild and certainly moderate Alzheimer's disease. And then we add Namenda in when somebody has reached the moderate stages, and they do not reverse anything that's already been lost. They certainly do not cure, but the goal is that they do help to stabilize somebody who hopefully is at an optimal level of function, so we can kind of postpone that need for heavy-duty care. But inevitably on this drug or any drugs, people do get worse over time.
Fazio, we have another question from somebody on Twitter, and that is, in your opinion, as Director of Special Projects at the Alzheimer's Association, how should healthcare facilities be designed for those with Alzheimer's, those with dementia? What should they look like? What should they feel like? What should they smell like?
Well, that's a difficult question and a big question. You know, we actually have resources for people. We have dementia care practice recommendations, the Alzheimer's Association, that really help people think about those types of things. I mean, like I said earlier, I think you know, the fundamental components of good care are that it's person-centered and it's relationship-based. And so I think you know, not that it's that simplified, but I mean, it's really places that really look at the person first and structure programs and environments that really meet those individual needs wherever they are in the disease, whatever types of symptoms or behaviors they might be experiencing, and that it's all based on maintaining a relationship with that person, that the care providers know something about the people, who they are, who they've been, and how to connect with them. You know, it's so much about the environment that the person's in that could really make the disease experience quite different than a non-supportive environment.
I guess I'm going to ask you a question that I know only too well from my personal experience, which is, in these healthcare facilities, a number of Alzheimer's patients get violent towards those who work there. They feel threatened since their brain capacity has altered and their brain function has altered, and they lash out. How do you train people to deal with these issues?
I think really trying to help people understand that the majority of the time it's our reaction to the person with disease that's causing them to act that way. And so it really is taking a step back and thinking about, how did we approach that behavior, and how did we maybe lead to that reaction. You know, sometimes it's stuff that's going on within people, but other times, and most of the time, it really is how that situation was handled that can make it a more catastrophic situation.
I'm gonna second Sam's comment here. I recently visited a facility in Southern California run by Silverado, where they really train the heck out of their staff, and where when you walk in, the place feels like a large residence. There are dogs, there are cats, there are lots of small dining rooms so entire families can come and spend time with the person with Alzheimer's or dementia. It's a dementia-only facility. And when you do see strange behaviors, the staff will go up and sort of envelop, hug, driven by a culture of the proposition that love is more powerful than fear. If you fear the behavior that's strange in front of you, you will elicit greater anxiety and, as Sam said, evoke sometimes reactions from the person with dementia that are totally unintended and not necessarily driven by the disease, but driven by the environment. But I will tell you that when I asked why, what's the barrier to the scaling of this kind of level of care, the answer was management and training. The ability to develop through your hiring practices and your training practices, people who have the attitude that if I love this person and don't fear them, then I can overcome these kinds of otherwise seemingly bizarre or violent behaviors. That particular home has cut down psychotropic drug use by 50%. People who come in violent and strapped down turn out to be, over a period of just a few days or weeks, much more peaceful because of the environment in which they find themselves. So Sam has hit the nail right on the head with his comment on this. I think he's exactly right.
And if you look at the...
Dr. Eakin had something he wished to say, and then I'll get to you, Dr. Brandenburg. Dr. Eakin? Dr. Eakin? You're muted, Dr. Eakin. Dr. Eakin. Oh, I think we'll go first to Dr. Brandenburg, who's not muted, and then we'll go to Dr. Eakin.
Oh, so what I was going to say is that even if we look in the hospital setting, giving someone uninterrupted sleep at night, which seems like an oxymoron in the hospital, but if you have somebody coming in every few minutes to poke you, take your blood pressure, do other things, that can make someone who's cognitively impaired get very agitated. So if we look at simple procedures that we do in the hospital, we can make a big difference, reduce agitation, reduce the use of psychotropic drugs, but it really requires a global kind of cultural shift.
Okay, now we're going to go to Guy Eakin, who I hope is back on. Is he back on? I don't think he is muted. I am so sorry.
Judy, can I add something really quick? This is Sam.
Sure.
I just wanted to go back to your question that came about design, and just I know I touched on it a little bit. George touched on it a little bit, but I think a lot of places will spend a lot of money on the physical design of their environment to try to make it look a certain way. None of that means anything if it doesn't feel a certain way. So less concentrating on the physical design and more really on the feel of home and how we could really concentrate on making these places feel more like home rather than just look like home.
Well, just a question, and this is just me speaking as a layperson. Isn't it a fact that if you walk into a healthcare facility and your brain is in some way impaired and your thinking is impaired, something that looks like home might be extremely important to the individual. More important perhaps than anything else. I'm just suggesting that.
Well, definitely something that looks like home. So I guess I'm saying that something that looks like home and feels like home is ideal. But if it just looks like home and doesn't feel like home, then the relationships aren't there. The connection isn't there. It's just a place. So the feelings can still be a lot different and a lot scary, and can lead to to other actions because of not really having that connection. So I think it becomes our responsibility to maintain those connections.
Let me just get to Guy Eakin, who has been on mute for a long time.
I think so.
Come back in.
Can you hear me now?
Yes, I can.
All right. Verizon would be proud.
Okay, Guy, you had something you very much wanted to tell us.
It's been long enough. I think that I can't recall what that was at this point. I do apologize for the technical issues we're having. The computer keeps crashing. So,
okay, Dr. Brangman, you were about to say something.
Well, I was going to say it's very easy to pick out curtains and matching wallpaper and put a potted plant in the lobby. The hard work comes in providing appropriate staff training. So you don't want to feel like you're in a hospital. This is probably not the best time to have a roommate. That's gone from the college days. But I think staff training is the hard work of these kinds of facilities, and certainly in a hospital setting, because that's the most valuable resource, and that's the one-on-one care that everyone needs at this stage.
I know of specific training programs that are very innovative and that might teach personnel how to react with people with dementia and Alzheimer's.
Yes, of course, the Alzheimer's Association programs. There are a lot of good programs out there all over the place, of course, but like I mentioned before, the association brought stakeholders from all different environments together to come up with dementia care practice recommendations that then resulted in training programs that are available both as stand-up courses through our chapters all over the United States, as well as online through programs that people can take online. I think the key is, and I know folks have touched on this before, is that we have so much work to do as a country to really get training as part of people's education. So we're really looking at ways that we could bring good quality dementia care standards in at a bunch of different levels, right at the school level on people's certification, as they continue to have education through continuing education, and then also through any type of licensure exams or things like that. And we're making advances state by state with that, but hopefully the Alzheimer's plan, the National Alzheimer's Plan, will bring us to a bigger level for all of that.
I have a question for Guy Eakin. Guy, since you're Vice President of Scientific Affairs at Bright Focus, I'm going to ask you a toughie. And that is, would you want to take, as you know, scientists in this country are developing markers for Alzheimer's. Would you want to take one yourself? Would you recommend it to friends or relatives?
I mean, it's an interesting question, and I actually, when I talk to some of our scientists, I know there's one scientist that has one rule in his laboratory, and he says that nobody can genotype themselves. Any of his staff cannot genotype themselves for a particular gene because it's too much of an emotional burden for someone to bear if they find out at a very young age, that they may be at a higher risk for this. But the quick answer to your question is I'd have no problem with that. I think what it affords in terms of my ability, or if I were considering that with a family member, what it affords in terms of my ability for planning and for engaging. Let's say we were talking about a relative, engaging them in their own plan and making sure that we know what their desires are. I have no problem with that.
Really,
Well,
Dr.
I would just raise a little bit of caution, though, because I do have adult children who ask me this all the time. And right now, we don't know what turns genes off and on and what makes a biomarker appear or not. It is a huge burden to live with. It can have a lot of ethical considerations, and it may impact your ability to get certain jobs or to get long-term care insurance or life insurance. And so we don't have enough information yet to know the significance of this. So outside of a research study, I'm not sure I would recommend general screening of any of these markers until we have a cure and or until we have a better sense of what those markers really mean for you on a personal basis.
George, I'm going to ask you the same question.
Well, I think this is a real dilemma. You know, being close to this disease, on the one hand, you'd like to know everything about your future and about your risk factors and what you ought to be doing to prepare yourself for the rest of your life, time with family, time on a job, whatever. On the other hand, there is not much you can do if you are otherwise engaged in a healthy lifestyle and otherwise managing your comorbidities. So my wife and I have not gotten genotyped, we haven't been motivated to do it, and we haven't been motivated not to do it, but we have not done it.
Now, this is a question I would like to once again ask Dr. Brandenburg about, and this is from a Facebook user, Marissa Pearl Snap, and she asks, when is the appropriate time to discuss the risk of dementia with patients and their families? What coping mechanisms are most effective?
Well, the risks should be discussed when somebody has high blood pressure or diabetes, when somebody's obese or they have high cholesterol. I think those are clear markers we know for cardiovascular health, and they also can impact brain health. Because it's such a prevalence in older adults, and I tend to see most older adults, we generally have a conversation about advanced directives in general and planning and what you would like to do, where would you like to be, to make sure someone has a healthcare proxy, somebody who understands your values and your wishes, because you cannot predict every scenario as you're sitting in someone's office. So you need somebody who can kind of be flexible and discuss things as they occur. So it's kind of a double-pronged approach. When I have somebody who comes in and we make the diagnosis of early Alzheimer's disease or another dementia, we definitely include this advanced planning and discuss values and wishes at that time.
Okay, thank you very much. I'm going to ask this of George Freidenberg again, and it's a question from Ellen Silvius on Twitter, and I suspect Ellen is fairly young. She asks, how much money will an 18-year-old today need to be able to take care of themselves at age 65 until death? George, I want you to take out your crystal ball.
Well, I think the best of assisted living, depends obviously a lot on inflation and the like, but I'll put those aside. But today, the lowest cost nursing home is easily $30,000 a year, and I would say assisted living at a really pretty good quality is $120,000 to $150,000 a year. Now, most people are recommended that you will, on average, spend about 3 to 4 years in some sort of residence. So that means, you know, perhaps $500,000. So of course, that is in today's dollars, and that assumes that you do not have a significantly longer period of disability, which requires your stay in a residence longer than that. It's very difficult. I do think, Dr. Brandon earlier mentioned this. We need to be thinking much earlier in life about saving for retirement, because retirement is so much longer, particularly for an 18-year-old today. Retirement could be 35 to 40 years. if you're thinking that you're going to retire at 65, which probably you won't. But even if you're retired at 70, you're likely to be retired for 25 to 30 years. That's a long period of time if you're going to rely on your personal savings. So starting very early in a personal savings account, having the discipline to put, particularly starting at 18, that much aside every week or every month, but really staying disciplined about saving during your entire life is clearly very smart, because my guess is that Medicare will not be there for you in the way that you think it may be for today's adults, and it's quite possible that Social Security is not going to be very significant in terms of income that's going to give you at that age. So I think that there's no question that we have to find mechanisms to encourage Americans, perhaps even incent Americans, to start saving very early and doing it consistently during their life. There have been some proposals that says at the time of birth, an American citizen ought to have $1,000 put into a health savings account and allow that to accumulate during the course of his or her life, and indeed encourage people to put money aside, allow that savings in those health savings accounts to accumulate tax-free and to pay for chronic care costs, because disability can hit you at any point in life, but to pay for the cost of disability at some point during the course of your life, but encourage that kind of savings almost from the date of birth.
I'm going to ask Dr. Fazio on the same subject. Should we really be putting the onus on the individual who is getting older or who is destined to get older? And shouldn't we be demanding more of our government? I mean, these healthcare facilities, these long-term assisted living facilities cost, as George has just said, a fortune. Many Americans won't be employed for 65 years or 50 years. Shouldn't we be demanding of our government that they take care of us when we're old?
Definitely, and I think that everybody sort of touched on that at some point or another in this discussion, but we definitely need to look at a better way to care for older people in this country, and hopefully we'll be making some inways with the National Alzheimer's Plan for people with Alzheimer's disease. We'll be making a start so that we can have a large plan to really deal with this tsunami. But I totally agree, we need to look at a way that that we can really meet the needs of this growing population, and possibly look at other countries as examples.
Dr. Brandenburg, I wanted to ask you specifically, when you see, since your area is older people, when you see older people, are they aware of the costs involved in their ailments and their diseases and dementia? Is there any way for them to wrap their minds around this issue?
Cost is a very prevalent issue. Most of the patients that I'm taking care of right now are survivors of the Depression era, and they've been saving for a rainy day, and sometimes they don't recognize that this is the rainy day. They're very concerned about running out of money. They're very concerned about being a burden to their family. In fact, that's one of those things that I hear on a regular basis. They don't want to be a burden to their families. They have great concern about what their kids have to do for them. So this is very prevalent. There's so much confusion about who pays for what. I have patients that are in that gray zone where they don't quite need a nursing home, but they can't live independently. And a lot of that care comes out of pocket, and people impoverish themselves. It's very hard to save enough for this kind of care because costs go up so reliably every year, and our healthcare system is very fragmented so that the care isn't happening in a coordinated way. It takes a lot of extra work to make it all happen in a smooth way.
To a more delicate question as a follow-up, Dr. Brangman, do some of these patients talk about ending their lives prematurely as a way of getting out of a very difficult situation?
In general, no. I can go to cocktail parties where people will say, if I ever get like that, take me out back and shoot me. And it's kind of like the standing joke. However, when people actually get to that stage, most of them are not thinking that way. And I think a lot of that has been overblown. in the media, although there are people who do end their lives, and we do periodically hear about homicides, suicides, and things like that. That's not the general rule. I think that we have the ability to solve a lot of complex problems in our society, and I think this is one of them that's within our ability to solve if we can get by all of the political discord and roadblocks that are out there.
I'm going to ask that same question of Dr. Fazio, I guess, because he's with the Alzheimer's Association. Do people talk to you about ending their lives prematurely as a way of not facing the difficulties of aging and dementia and Alzheimer's?
That's a good question, and it does come up from time to time, but it really isn't something that we hear a lot of. I think now, we have the early stage advisory council, where we bring people with early stage together and find ways to make their voices heard. And I think really helping to educate folks about the disease is really number one. And educate the person with the disease, or the person who may be getting the disease, as well as caregivers, because there still is so much stigma around this disease that we really need to work on, so people really have the accurate knowledge about the disease, so they really can think ahead and plan as comfortable as it is for them.
Judy, it's interesting. You use the word prematurely in their life. We are all going to die. And I guess the question is, what's premature for one person is maybe appropriate for another person. But we, in this country, we cannot in the public discourse talk very often about what a good quality of death is. That you have palliative and hospice care at the end of your life, which will, to the extent that's conceivably able to do so, make your quality of life near the end of your life as great as it can be. And the constant commitment to machines and to mobilizing every last ounce of human energy towards extension of life sometimes can make the quality of life near the end of life pretty terrible for those that do not make clear their wishes early. And because there is going to be an end of life, and better that you make clear how you would like your life to end, at what stage and what circumstances, than putting you through what undoubtedly is, in so many instances, this struggle at the end of life to try and keep, your mother or your father alive against all odds and against the inevitability that they're going to die. They should die a quiet and quality death, and not one that's strained, it's in and out of hospitals, it's constantly on machines. As Dr. Brandon has earlier pointed out in another context, constantly poked and prodded for the last hours of your life.
I think that's another area where we're in denial. We're in denial about aging, and we're in denial about the end of life. I take care of patients all the time in that phase, and there's often a delay in people accepting. They go in within the last 24 hours of life, and therefore they miss that opportunity to have a good death. And that may sound like an oxymoron, but you can have a good death with the right people trained to help you.
And your family around you, and saying goodbye in a loving way, rather than your family's being dispersed and not there, and otherwise struggling.
I agree.
You're one of the few doctors, Dr. Bragman, I've heard talk that openly about it. And George, I gather you've been giving a great deal of thought yourself to this issue of a good death. I know that does, as you said, sound like an oxymoron, but it is something we all have to consider.
There's some at least anecdotal evidence that, in fact, if you have a hospice type conversation, not in the last 2 or 3 months of your life, but 9 months or a year before, and you emotionally accept the proposition that you will die, and you feel that you have a degree of control over the circumstances, understand that you will not be in pain, and can plan it with your family and the like, that you actually have a better quality of life in the last period of time in your life, and emotionally a better death, because of the ability to connect with families, to resolve issues, to otherwise deal with things in a way that you complete your life rather than having this feeling, oh, I've struggled for the next hour because I want to live one more hour. Well, you're going to die. So at some point, and I'm not suggesting that we ought to encourage people to commit suicide early. I'm not saying that at all. But I am saying that we need to understand the inevitability of death and the idea that you can plan a better course near the end of your life than a bad one.
I wanted to ask Dr. Fazio if just what George and Dr. Brangman were saying resonates with you as well.
Yes, definitely. I mean, I think that we moved, I think your original question was about somebody taking their life, and I was assuming that was sort of earlier on in the disease, whereas now we're sort of talking about end of life and, you know, palliative care as well as hospice care. I definitely agree with what both of them said. I mean, I think it's important to have that conversation earlier. It's important for us to have that conversation as an entire what's the word? Entire sort
Society.
of society. Thank you.
Society, family, community.
Yeah, thanks. But we really need to look at death like we were saying about aging too, and really help people plan ahead for that and plan ahead for how it is they want to experience that.
I know exactly what you're talking about. One of the first things that surprised both my sister and me when we were looking at long-term care facilities that dealt with Alzheimer's is that a middle-aged man whose father had advanced Alzheimer's said he was so glad that facility was right next to a hospital because his father, who had very advanced Alzheimer's and was dying, had had a heart attack, and he was so glad that the heart had been repaired. And my sister and I looked at each other and we thought, I don't know that that's the right resolution of this issue if you have advanced Alzheimer's and are dying anyway. So
well, there are numerous cases where I have heard anecdotes again, where 95-year-old women are getting mammograms, and you know, and they're in a moderate to late stage Alzheimer's, and you say, what are we doing here? We have a procedure, there's a rule that says you have to get a mammogram every year, but at a certain point common sense kicks in to say, in fact, there are excessive procedures with respect to, you know, people in later stages of this disease, which really, on balance, of course this is a family decision and not, you know, necessarily society's decision by any stretch of the imagination, but where your judgment would suggest that these are excessive procedures that may in fact create more harm than good.
Very true.
Dr. Brangman and Dr. Fazio and George Bradenberg and I would like to, and Guy, of course, Guy Eakin, who's back with us. I'd like to thank all of you for participating in this fascinating discussion about the tsunami of dementia that is coming fairly soon. I see from the clock that our time is about up, and I know we could talk about this forever and ever, and we'd still have more ground to cover. But I'd like to thank all our team membership who generously participated today. And thanks to everybody in the TEDMED community, particularly to all of those of you, and there are quite a number of them, who sent in questions via Twitter, Facebook, whatever. We very much appreciate your questions, and we very much appreciated the answers from our panel. As I mentioned, this dialogue will continue at tedmed.com. You can also post comments and questions on TEDMED's Facebook page, and we welcome everyone's input. Join us for our next live events discussing active lifestyles on Thursday, February 28th at 1 p.m. Eastern Standard Time, and wellness programs that work that same day at 3:30 until 4:30 Eastern Standard Time. And finally, we want to say thank you again to the Robert Wood Johnson Foundation, which sponsors the Great Challenges program, and to our wonderful panelists. You've been terrific. All the best to everyone out there. Thanks. Bye-bye.
Thank you.
Thank you.